welcome to a new episode of Amref Health Africa's and Kenya's podcast, Governance and Strategic Partnerships Towards Achieving an End to Maternal Mortality in Kenya. I'm your host, Halima Sabwa, diving into a critical issue that is at the heart of Kenya's healthcare challenges, maternal mortality. According to UNICEF's report on maternal and newborn health disparities in Kenya, approximately 92 babies will die each day before reaching their first month, and 96 stillbirths occur every day. To further expound on this, we are honored to have with us Dr. Chris Barasa, Chief of Party at Amref Health Africa in Kenya, who is also overseeing a USAID-funded project on governance and strategic partnership. And we also have Dr. Nelly Bosire, who is an obstetrician gynaecologist in private practice, but has also done a lot of work with the Ministry of Health and the Medical Council in shaping the discussion around neonatal and maternal health. And together we'll be exploring how Amref Health Africa in Kenya, in partnership with the Ministry of Health and other stakeholders, is steering initiatives that aim to provide accessible, quality healthcare for expecting mothers, especially in remote areas. Our guests will share enlightening perspectives on the progress made, the challenges encountered, and the impact of these partnerships on the ground. So, before we get into the podcast, let's learn a little bit more about our guests. So, Dr. Chris Barasa, I know you've been here before. Welcome back.
Yeah, I've been here before.
And
I'll come back more time.
Please, karibu.
Yeah.
And what was your favorite subject at school? And how has it influenced your career?
School. Wow.
Primary, university, secondary, any?
Mathematics.
Mathematics?
Yes.
Oh, okay.
I used to crank the numbers. And I still do that even now.
Mm-hmm.
Even as we talk about maternal mortalities, I'll take you through some numbers.
Okay.
Yeah.
So, just... And
yeah.
Dr. Nelly.
Yeah.
Dr. Barasa.
No, not math. I did like math, but I actually liked tinkering with electricity.
Okay.
Yeah, I know, weird.
So you guys were pretty much STEM, science, technology.
Yeah.
Yeah, more or less. Yeah.
And so, Dr. Nelly, you said you're not like really a math person, but your entirely different career path, what would it be?
Professional dancer.
Why?
Because I would never have to work a day in my life to lose weight. It will come with a job. But I do love to dance. I actually do a bit of salsa and stuff like that.
Okay.
But if I could get paid to do that all day, I definitely would be happy to.
Oh man, that's amazing. That is awesome. I have never salsa danced, but and I'm sure it's like really good for you as well.
It's amazing for cardio.
Yeah, yeah. And Dr. Barasa, have you ever danced before? Okay. So
The only music I dance to is rumba. That one at least I can move.
okay, but getting back into the podcast about governance and strategic partnerships to reduce neonatal and maternal deaths in Kenya. How are strategic partnerships between Amref Health Africa in Kenya, the Ministry of Health, and other stakeholders critical in addressing maternal mortality?
Yeah, and thanks, Halima. Let me just go back a bit to why we are here, and I want to really just appreciate that we got some funding by USAID to be able to support governance and strategic partnerships, but aimed at actually delivering on a very specific mandate. And so one of the deliverables that we have as a program is basically to ensure that we harness strategic partnerships for us to be able to achieve end to preventable maternal mortalities in Kenya. So having a strategic framework basically will be able to enable us to achieve two things. One is we'll be able to optimize our individual, as organizations, technical know-how and capacities for us to be able to put together our thoughts and develop a roadmap that can be able to support towards ending maternal mortality. But at the same time, we'll be able to put together our resources so that we reduce duplication. We work in a health system that is relatively very fragmented. But what that means is that everyone does a bit of each of the bigger piece. And what that means that sometimes there's duplication of efforts, and then we don't seem to be well coordinated. So working together with the Ministry of Health as our, let me call it our mother, our umbrella, to be able to put all the partners in this space will go a long way in enabling us achieve this. And we've made quite a number of strides so far. As I mentioned, just had a meeting this morning where USAID and other implementing partners in this space were WHO, UNICEF, and we're just discussing how can we put together a framework towards end to maternal mortalities in Kenya by 2030. The other process that we have undergone that is seeming to be fruitful is engaging the Ministry of Health through the Strategic Partnerships Department, and that is proving to be very helpful. Through the Division of Reproductive Health, that's proving to be very helpful. Through the COG, that's the Council of Governors, it's proving to be very helpful as we just bring together all this. We aim at actually having this discussion of strategic partnerships at the highest office in this country, the presidency, so that we can be able to have this discussion at his doorstep. Because when a mother dies, it has very, very serious ripple effects, rather, downstream actually, from the mother herself, the family, the children, and all that. Yeah. So we really wish that just the way President Moi pronounced himself on the issue of HIV in 1993, Halima, maybe, let me not try to say that. I don't know how old you are that time. But the point is, in 1993, President Moi pronounced himself on the issue of HIV and said it's a national disaster at that point in time. And that statement alone marshaled a lot of partners together. And there are a lot of gains that have come just by that pronouncement. So we are looking at, can we have a similar pronouncement by the presidency on the issues of maternal mortalities, so that every one of us can rally behind this, mobilize our resources, optimize our resources, and see how that can work towards ending maternal mortalities by 2030. Thanks.
You're very welcome. And I really like the point that you made about the duplicity of content and fragmentation within systems, because one of the only ways that all of this can be incorporated in terms of strategic partnership is working with the Ministry of Health as an umbrella, so that all of these stakeholders and partners can come together and work in tandem, reduce resources, and also work together to achieving the end maternal death by 2030 framework. And that being said, Dr. Nelly, as part of the Ministry of Health and working with the Ministry of Health, can you share details about specific initiatives aimed at reducing maternal mortalities, and what progress have these initiatives made so far?
Well, there has been plenty. I think famously, if we just go back a decade, one of the biggest steps that were taken in this country is the introduction of free maternity. And that is possibly one of the biggest things that was done, because first it came from the government. This was a pronouncement by the president, and it meant that everybody had to abide. The goodwill alone that came with just that statement was huge. And we went through a phase where the First Lady then did a huge campaign in creating awareness about maternal mortalities and the mobile clinics that went out there and all that. So walking through that decade, we have been able to see remarkable improvement in certain indices that we look at when we're having a conversation about maternal health, about neonatal health. And this is completely in line with looking at our SDG 3132, that we have to reduce maternal mortalities, we have to reduce neonatal mortalities. So we may not yet have come to the impact of numbers, but the one thing this decade did is creating awareness. There is nowhere in this country you will go and meet a mom who doesn't know that delivery should be under a skilled health professional. That was not the case a few years back. And it also coincided with devolution. So then counties that for the longest time had really suffered a great deal were now able to speak as independent entities, because we would talk about maternal mortality in this country, But we weren't saying we may be having a maternal mortality of 368 per 100,000, but in Mandera it is 3,000 per 100,000. But now Mandera can speak for itself and say, over this decade, we've moved down from 3,000 to 800. So then what's happening? If Mandera is coming down, who is this who is going up? That is actually giving us a challenge that our numbers are plateauing instead of going down. And so that awareness, that everyone being aware, meant first that we increased facilities across the country. Devolution came, towns grew. Little counties that did not have headquarters suddenly are now becoming cities, literally. We're not only seeing the county facilities growing, we're also seeing smaller ones that were dispensaries are being upgraded to health centers. We're seeing health centers being upgraded to sub-county hospitals. Places that were run purely by nurses now have medical officers. So that has slowly been moving. Facilities that could not provide the service are now able to provide services, even if not necessarily at comprehensive care level, but at least at basic care level. So knowing that we are beginning to put the infrastructure in place, then we know we can focus on these next remaining years on looking at improving the quality of service in there. So we've already done step one. Created awareness, ensure that these facilities are coming up. And they're not just coming up in public, they're also coming up in the private sector. Our faith-based institutions have expanded. Hospitals like Kijabe now can talk about having branches. That didn't exist before then. So that went a long way in drawing attention to maternal health as an individual and newborn health because it's a product. And so when we're talking about how do we improve quality, now we're beginning to go back all the way to our WHO pillars. How can we improve the service that is offered so that it is actually a productive service that ensures that we have better outcomes for our mothers and babies? And so in that space, we have had a lot that may not necessarily have been fully speared at national level, but has gone through partnerships, through research. For instance, we have had the Emotive trial that was bringing together a lot of partners, and they were looking at prevention of postpartum hemorrhage as the number one leading cause of death in maternal health. And not only was it just enough to improve the response to postpartum hemorrhage as an emergency that happens in care, but also to improve commodity supply. And the amount of advocacy that went into it brought partners together to rally with the Ministry of Health to actually ensure that drugs like carbetocin, which are actually quite expensive, have now been able to be availed for our public health facilities. They stop being just the preserve of those who can afford it. And now we know that from KEMSA, this can actually be ordered and stocked in our public health facilities at a very nominal fee. You don't get those kinds of concessions without partnerships. And those have been very key. So going forward, and what I love about this is we all are on the same page. We want the same things. We all bring different strengths. So, for instance, for the longest time when we would talk about interventions, we didn't put a lot of focus on commodities. What is the quality of commodities we are getting? What is the access to these commodities that we are actually getting? What is the rational use of these commodities that we need in our setups? And so what MOH has been responsive to is that it has actually continuously been upgrading its guidelines, practice guidelines, standards and guidelines on how we practice, and including all these things. So you will find that, for instance, just last year, we had to have a review of the standards and guidelines for maternal, like emergency maternal care at the Ministry of Health. And we have actually added carbetocin there as one of the drugs that are required in our setup for combating something like postpartum hemorrhage. So about 2 decades back, we were going through this with the preeclampsia, trying to ensure that magnesium sulfate was incorporated into our care use, that people were trained all the way to the little health centers that deliver mothers on how to use magnesium sulfate. Now it's mainstay. When we talk about postpartum hemorrhage, we want the same. And so we're slowly improving quality. We just want to move away from fragmenting parts of care and looking at that quality to say, how do we make the wholesome care of this woman from preconception care all the way to postpartum care to ensure the best possible outcome for mother and baby, and look at all these different aspects. How do we strengthen them along the way?
And I love that point, because holistic healthcare is important. Holistic maternal healthcare.
Absolutely.
Because a mother is going to need checkups. She's going to need throughout her whole pregnancy. Even after, you're going to need care. And I also really like how you brought devolution into this, because with devolution, you're seeing different counties developing differently, especially as it pertains to healthcare. If you're looking at Gladys Wanga and what she's done in Homa Bay with her hospital and maternal care, it's amazing,
It's
you know.
amazing.
And that would not have happened if it were not for
Devolution.
you know, devolution, and having counties actually speak for themselves. Hilary Bakok is another governor who's done amazing work with his facilities. So I think that is really true. And the first step was creating awareness.
Absolutely.
Creating awareness, you have to change policy, and you have to have a holistic system and approach, so that equitable healthcare access is given to everyone, and not just in urban areas, but in last mile communities. And we've talked about some of the challenges being fragmentation. Dr. Chris, what would you say are the most significant challenges in reducing maternal mortality in Kenya? And how has Amref Health Africa overcome some of these obstacles?
So, thanks, Halima. I think in responding to that, allow me to get into the scenario of my aunt who died in 1999 because of PPH. Okay. So that you can understand better. It's not being hypothetical, but just trying to find out what are some of these things that actually led to her death. Okay. There's an aunt who passed on in 1999. Actually, it was 31st of December 1999. And the circumstance surrounding her death is basically she went into labor at night. She comes from an area that Mount Elgon, actually, an area that's quite hilly, so transport is an issue. So she couldn't be able to go to hospital that night. Then she ends up delivering at home, okay, by the help of the Mkunga.
A midwife.
Mkunga is a midwife.
Okay.
I won't call them a midwife because I don't think she was a qualified midwife. This traditional birth attendants, you know, the way you are in the village and someone says, "I've delivered all of you," proudly so. Even they will tell you, even myself, I've delivered myself. Yeah, all these 9 children of mine, I've delivered myself, and they very confidently talking about that. We have such actually kind of scenarios. So yeah, so I later learned that she actually, because at that point in time I'd just done my form 4, and it was a bit worrying. For information, that's why I came to do obstetrics, because I said I need to do something about, at least I need to save a few lives. I didn't save her life, but at least I need to save a few lives. But by and large, I came later to learn that she actually had what we call a retained placenta. Okay, so she bled. By the time it was morning and she was being now taken to hospital around 5 in the morning, she just arrived and then collapsed and pronounced dead, for that matter. So I always want to take us through the journey that this lady walked before she died, and those are some of the challenges that you will actually meet. One is the issue of infrastructure, poor infrastructure. And when you're talking about strategic partnerships, then we must think beyond just health and ask ourselves, what are some of the social determinants of health that influence whether a mother will die or not? So the poorer your road network is, the more likely it will happen. Unfortunately, at that time, even the phone penetration was not very, very good. So technological disadvantages. Most women who die, if I look at the counties where we have high mortality rates in this country, even technologically, they are not as advanced. compared to some other parts of this country. You go to Turkana, for example, there are parts when you reach, there's no network. So even if there's a hotline for you to call for an emergency, you can't just call in the first place. So technological advancements actually have been associated. So that's one of the second challenge that I want to talk about as I walk through with this mother of mine, rather auntie of mine. The third issue is basically at what point the decision making, okay? Because of course they thought it was at night, so it was difficult for them to go to hospital. But the fact that the TBA was there, I think it makes the husband or even the lady a bit more comfortable that someone will deliver me. The fourth thing that I would want to talk about is the distance between the community and the hospital where she delivered. She was taken for review. It was about 8 kilometers, okay? In a very, the infrastructural aspect of it notwithstanding, but the distance between the primary facility and where she stays was a bit long.
Yeah.
So what Dr. Nelly was talking about in terms of just improving access as a government initiative for us to see how can we improve access to at least level 3 and level 4 health facilities, where you can be able to get a theater, or you can get comprehensive maternity care in case an emergency happens, for that matter. So it's a challenge that we have. You look at the coverage of this. In Turkana, where Amref has had a lot of presence, the distance between the household and the nearest health facility, on average, is 30 kilometers. So you can imagine if you're pregnant and you get into an emergency scenario, 30 kilometers in that dry area.
On a motorbike.
If you are lucky to have a motorbike, for that matter. I used to see mothers walking in the scorching heat, actually, going to look.
And that stress can make someone have
It will just worsen everything, for that matter.
Yeah.
So that distance is very critical. And there are some interventions that, as Amref, we've been trying to put in place. For instance, in Turkana, a lot of work has gone into community outreaches. There's a model called Kimormo that we really, Nelly has been there, and she published something on that around Kimormo, in terms of how can we have one health approach and bring services closer to the mothers. So what we usually do is to have support the Ministry of Health, the county government, to have monthly outreaches. And Halima, that is going to be a paradigm shift if done very well in as far as maternal mortality is concerned. Why? Because a primary care network is going to be the most comprehensive functional healthcare service delivery unit, all the way from the community to the level 4 hospital or a level 3 hospital, the spoke and hub model. So the point is that we will, within that primary care network, using the community health promoters, really have a situation where all the mothers who are high risk, first of all, identify all mothers who are pregnant, disaggregate those who are high risk, low risk, and then have differentiated messaging to the women depending on the risk classification that you have. In that case, the community health promoters who meet these women on a regular basis will be empowered actually to provide relevant information as and when to identify what we call danger signs in pregnancy. We believe that if this actually is well structured, then we'll be able to significantly reduce the maternal deaths that happen, sometimes go unreported in the community. The last thing that I want to talk about in terms of the challenges and how as Amref and how as a country are working around this is the issue of data. Okay, the issue of data. I'll show you. There are some line graphs that we've developed that show that actually as a country we are stagnated in as far as maternal mortality is concerned. Point being that for the last more or less 7 years, actually the scenario is worsening. Okay, unfortunately,
Mm-hmm.
because you can see that
Yeah.
the scenario is worsening, while other countries are really going down. Kenya has been plateauing, and unfortunately has started going up. And this data from WHO, World Bank, UNICEF, they have a team that looks at all this data for all the countries globally. And we're asking ourselves, where are we going wrong in as far as this is concerned?
Yeah.
One of the things that we really want to think about is, how is our data? How is our data flow? Okay. What kind of information are we getting? What are we reporting in the first place? Is there a chance that we're even having more deaths than we have reported? Or is there a chance that what we are reporting, there's no verification, and therefore we are overestimating? So it's both ways. Either we are underestimating or overestimating, depending on how the quality of data that we have
Or
is
maybe we are also shocked
Or maybe
because
actually
now our
shocked.
mothers are delivering in health facilities and we are
Exactly.
better able to actually capture
exactly.
what was otherwise lost in the community.
Yeah.
Exactly.
Yeah.
Yeah. So the point is that data will help us to make better decisions, informed decisions.
Yeah.
So data for decision making. And the primary care networks have a very clear way of on how this should happen. And one of the things that, as we partner with other organizations, other entities, the Ministry of Health, that we want to look at is to really embed the data flow systems within the primary care networks. We will wish to have a dashboard that if a mother dies in Kuresoi, for example, it's picked immediately and transmitted. Then we are able to actually know and do what we call an MPDSR. So we do a review to just find out what caused the death of this mother, real time, okay? So that we can have an immediate action towards that. But most importantly, Halima, is for us to be able to identify what we call near misses. So these are scenarios where there are circumstances where if you don't do anything about that scenario, then this mother is likely to die. But if you have some intervention, then that's what we call the near misses. You save this mother. So learning from that and asking ourselves, what are some of these things that if we do, then we will not lose a mother, rather than coming after a mother has already died for that matter. So data will tell us, and tell us, yes, this month we had 5 near misses, and these were the presenting conditions, and this is how we manage them. Then now we scale up as a learning agenda. So data will help us to be able to preempt some of these potentially disastrous complications that may occur from this. So we have quite a number of challenges. They look very, very significant, insurmountable. But our belief is by providing a platform for engagement across board, we should be able to work out on a formidable mechanism that will ensure that our mothers don't die from preventable causes.
If you have any questions, concerns, or queries, please connect with us at Amref Health Africa. So our Twitter is at Amref_Kenya, our Facebook is at AmrefKE, and our Instagram is #AmrefKenya. Thank you so much. I've been your host, Halima Sabwa, and goodbye for now.
Thank you.